So good afternoon, everybody, and welcome to our workshop on the 100 Days Mission, a session that will explore this ambitious goal and what it aims to accomplish, and why it is crucial to being able to build a future free of pandemics. We're joined today by leading experts in the field of global health security to address those important questions. We will also be joined later by Germany's Federal Minister of Education and Research, Bettina Stark-Watzinger. She will talk to us about the importance of investing in the 100 Days Mission and in CEPI. But first, to introduce the 100 Days Mission and the objectives of this session, please welcome the Deputy CEO of CEPI, Dr. Fredrik Christensen.
Thank you, Kate, and thank you all. And let me start, since we are meeting here in Berlin, and while we wait for the Deputy Minister, but also having Veronica von Messling here, to commend Germany for their leadership and focus in advancing pandemic preparedness and response agenda, both during the G7 presidency, as well as in taking leadership in global health more generally. Seeking to reduce inequity and recognize the problems that the pandemic has caused so far. And realizing that this has to be solved through global cooperation. And that is indeed why we are here today, to explore how we can try to revolutionize the way that we prepare for and respond to pandemics in the future. And an integral part of doing that will be to compress the timelines from a new threat appears to we have a vaccine available. And that will happen through an aligned R&D agenda, but also with clearer roles and responsibilities for all involved. Now, the 100 Days Mission that we launched in connection with the CEPI 2.0 plan that we have envisages a future in which vaccines against new infectious threats or disease X can be developed in just 100 days. And this aspirational goal gives direction to our aspirational plan for R&D to help the world end pandemics in the future. Achieving that goal will help the world and give the world a fighting chance to curtail outbreaks before they spawn into global pandemics. Thinking back, if the world had been able to develop a vaccine in 100 days for our COVID-19 pandemic, we would have had a vaccine as early as April 2020. At that time, there were only 2.3 million cases confirmed worldwide. So we can imagine how it would have saved millions of lives and trillions of dollars. And the mission is ambitious, but it is actually achievable with the scientific advances that we have had and that we've also seen develop now through the response to COVID-19. And it's a mission that has now the backing of G7 and G20 leaders. And it requires an understanding of how we can make sure that pandemic preparedness remains on the agenda and how pandemic preparedness is related to both global warming and global warming changes. Sorry. And how it also relates to the other crises like wars and economic challenges that we are seeing. Because one thing we do know is that COVID-19 will not be the last pandemic we face. The resurgence of polio that we're seeing, the ongoing outbreak of a rare strain of Ebola in Uganda, and the continuing global spread of monkeypox are all reminders of the fact that while threats are everywhere, they do not respect borders, as we know, and they will continue to pursue and exploit every crack in the armor that we put up. So we need to be able to adapt quickly, whether it's a new variant of COVID-19 or whether it's a new disease X. So to discuss this, I'm honored to be joined by a very honorable panel of speakers who will explore the technical innovations, the scientific and access challenges, the systemic improvements that we will need to address to accomplish this mission. And it will require a paradigm shift, but we know that if we can put together the agenda correctly, it is actually achievable also to help enable access. There's no doubt that the journey will be challenging. There are many scientific, political, policy, regulatory, and political hurdles that will need to be overcome. But I believe there is reason for optimism. As we said, world leaders have come behind the mission. We have CEOs of important companies that have aligned with it. And so I'm hopeful if we can make the right and the bold investments today, we can actually realize a future where dramatic pandemics can be a thing of the past. Thank you so much.
Thank you, Frederick. So the COVID pandemic has been utterly horrific and has brought the world to its knees, both socially and economically. But despite the death and devastation it has brought, it is far from the worst case imaginable. The threat of another novel virus, a new disease X, is ever present, unknown and unpredictable. But the amazing technical advances that scientists around the world have made during COVID-19 mean that it is now within our capacity to be able to create new vaccines and new defenses against viral threats in just 100 days. The question is, do we have the investment, the infrastructure, the sense of common purpose, and the political will to do this? So today we are asking, what does the world need to do to achieve the 100 days mission and to get ahead of the next disease X? To help us to provide some answers, please welcome our distinguished panel. We have on the line Dr. Iskra Reik. We have Dr. Soumya Swaminathan here in the room, Mr. Pierre Delceau, Dr. Ifedayo Edatifa, Dr. Bill Rodriguez, Dr. Ahmed Ogwell also on the line, and Dr. Frederick Christensen. So there will be an opportunity for you in the audience to pose some questions to our panel later on in the discussion. But first, could I start with an opening question to you, Dr. Reik, on the line? The global response to COVID-19 has led to a whole host of scientific breakthroughs in vaccine technologies. How can we build on those advances to enable a more rapid response to future pandemic threats?
Thanks, Kate. Hello, everyone. And sorry not to be there with you, but happy to contribute to these important discussions. Thanks for the opportunity to discuss learnings from the pandemic, and probably more importantly, how we can continue to work together to be better prepared for the future pandemic, as Kate already mentioned. Today, I would like to focus on the following 2 points. First, I would like to highlight the AstraZeneca contribution with the support of the key partners, including CEPI, to the equitable access to COVID-19 vaccine worldwide, which is a probably good example and good segue that can help us to talk and share today the lessons learned from the pandemic and how that can help us to be better prepared in the future. If I start with my first point, as many of you know, in a very early stage of the COVID pandemic, we partnered with the Oxford University to enable global development of our vaccine, its manufacturing and distribution. And the result of that public-private partnership resulted in a vaccine that was developed in under a year. Broad and equitable access has been at the heart of our response, and we do believe that this is critically important for us to take into account when we think about the response to the next pandemic. And we believe we made a significant impact in terms of the global public health by doing so. Based on the recent data published in Lancet, our vaccine is estimated to have saved over 6 million lives in first year of the vaccination. Supplying vaccine with no profit during the pandemic and supplying vaccine with no profit in low-income countries today is also probably an important topic and the takeaway that we should discuss today and think how that model can be enhanced in the potential future pandemic. AstraZeneca was also the first and the larger contributor in 2020 and 2021 to COVAX, and having that platform was critical for the response to the COVID-19 crisis. We do realize and support 100-day ambition, and I do believe that we all learn that that can definitely help us to better manage and save more lives in the next pandemic as we all support this ambition collectively. It is really important to reflect the lessons that we learned to support the future pandemic preparedness. And let me highlight the three that we believe are the key important for us. First and foremost, as already mentioned, public-private partnership and close collaboration between academia, governments, research, and industry is critical for accelerating and strengthening the response. Second, early investment in development and manufacturing, ensuring and reserving capacity led by government in collaboration with the industry will definitely help to secure capacity and enable access. Third, we all need to work together to transform clinical trials to the better digital infrastructure with, while greater international collaboration on regulatory approaches will definitely ensure and enable us to have to be in a better position in our response to the next crisis. In addition to supplying a vaccine for the world, I think it's really important to mention another important point, and this is commitment to support governments and NGOs in their vaccination efforts. And it's something that we tend to call last mile in the vaccination. Let me give you an example from Kenya, where we are engaging with the Ministry of Health with the support of and supporting AMREF Innovative Mobile Clinics initiative to accelerate vaccination coverage. These mobile units can provide the important channels for the last mile vaccination effort, as well as health education in the communities, including screening, vaccination, and urgent care. Looking further ahead, there will be many healthcare challenges, as my colleagues already mentioned, beyond COVID-19, which will definitely require us all to collectively think differently, as well as developing a better environment for the rapid development of the vaccine. We must focus on the resilience and sustainability of our healthcare system. Thank you for the opportunity to speak today. Kate, back to you.
Thank you. Thank you. I'd like to ask our other guest on the line, please, Dr. Ogwell, to make a contribution next. One of the things that will be crucial to us achieving the success of the 100 Days mission is greater and more regionally diverse manufacturing capacity, closer to where outbreaks are likely to occur. What do you see as the main challenges in bridging the gap between vaccine development and supply? And that's both on the African continent and elsewhere in other regions of the world too.
Thank you. Thank you very much. First, let me congratulate the organizers for putting this together. A very important topic, particularly now with all the lessons that we've learned. Let me start by making the obvious point that it's not vaccines that saves lives, it's actually vaccination that saves lives. So if we have vaccines and we don't have vaccination happening, then we are not making a good contribution to public health. And therefore, as we discuss and design 100 days, we need to be very clear in our minds, how are we going to get from the product to the vaccination? And this is a very big priority for us here in Africa. And Africa CDC will continue to champion that holistic approach where we don't only look at the product, but we also look at how it gets to the common person in the street. So there are three very important things that we need to be reflecting on as we think and design the 100 Days initiative. The first is we must, from the word go, ensure that the Global South is part and parcel of the development of any vaccine, indeed any product that we need in a situation of a health emergency. That means our research institutions need to be involved. That means that when there is any trials to be done, then the Global South needs to be part of that conversation. Indeed, our national regulatory authorities, our continental regulatory authorities must be part of that process from the word go, so that we are strengthening capacity even as we are designing response to a particular outbreak. So this is the first thing that I would say, the need for the basic developments of research to be in place and for the Global South to be involved. The second is we need a situation where access to a viable product has been worked into the planning. What we have now is a lot is going on in other parts of the world outside of Africa, to be precise. And when the product is made available, Africa is not only at the end of the queue, it is at the end of the queue probably 3-4 times because those who have the resources more available have purchased whatever is going to be manufactured. So access to a product must be worked into its development. Otherwise, if we develop a good product, it becomes inaccessible. Not just because one cannot afford it, but also sometimes because you can afford it, but you can't buy it because it is not there in the market for you to buy. So access is the second thing that must be worked into this planning. The third is the pricing. And the pricing needs to be designed in a way that it does not just make profit. We need to design pricing in a way that it actually serves a public good. After we've gone through the process of research, ensuring there's going to be availability, the price has to be at a rate that is going to serve public health. So for me, these three things are the ones that we need to be looking at as we design and we go ahead with the planning for the 100 Days initiative. And as Africa CDC, it forms part of our new public health order. Very important to strengthen institutions, have the right capacity on the continent, very important to go into partnerships that are going to make a difference, and very important to ensure that when the product is ready, it can be able to be manufactured locally, and therefore the whole globe is going to have easier access to any product that comes. This is true for COVID. It should be true for monkeypox. It should be true for Ebola, whichever strain we are talking about. It should be true for any other outbreak that has a major effect on our public health. And thank you very much for having me and sharing our thoughts as Africa CDC. Thank you. Thank you.
Dr. Egwell, thank you. Thank you. So I see now that our distinguished guest, the Minister Bettina Stark-Watzinger from Germany's Education and Research Ministry has arrived. If you'd like to come up and make some remarks, please do. Thank you.
Dear Mrs. Callan, you're right in the middle already of discussing the next steps to achieve our goal, our common goal, but let me take a step back maybe and make some general remarks. Dear Mr. Christensen, ladies and gentlemen, a tiny virus and its enormous impact. This could be the headline when looking back on the past 2 years. Each country had chosen its own way to cope with the pandemic crisis. We can see very different approaches throughout the world, from almost no restrictions to stringent zero COVID strategies. To put it in a nutshell, one problem, many strategies. Nevertheless, we have grown together during the pandemic, mainly due to science and the bridges researchers have built, working towards a clear goal to learn as much as possible about this virus as quickly as possible, and to develop vaccines to fight it at record speed. And we can say today, they have been successful. Everybody's talking about game changers. In this case, the term is really appropriate. This was a top achievement, and some of you were involved, and I need not tell you more. You were committed and continue to be so. You were bold, as mentioned, and you continue to be so. So thank you very much for your work. And the people outside the labs caring for the patients at their bedside, doctors and nurses and caregivers for the elderly, and I cannot name them all here today, we can only thank them for their dedication, extra hours and energy. During the COVID-19 pandemic, science has shown what is possible right now. Researchers have also given us a glimpse of what might be possible in future. We know that the quicker we respond to a virus outbreak, the better we can contain the impact of a pandemic crisis. Ideally, we can even prevent it from beginning a pandemic in the first place. We know that when vaccines are available, lives can be saved, and every single day counts, hence the 100 days mission. What does it stand for? You know that better than I do. For speed. Ideally, we will develop a vaccine within 100 days. The vaccine makes the pandemic less frightening. It restores people's freedom, and I firmly believe in science and translation that this will be the solution. To be able to respond quickly, we need agile structures, such as CEPI and its International Vaccines Initiative. The COVID-19 pandemic has shown that we need CEPI. 5 of the vaccines funded by CEPI have been approved for use so far. CEPI launched the second program period in 2022. Being able to develop and produce a new vaccine within 100 days, that is the goal. Furthermore, CEPI is investing in platform technologies. These technologies help us to quickly adjust vaccines to new pathogens. And what is more, CEPI works to ensure fair access to vaccines. COVAX Marketplace participation in the Act A initiative. This is where CEPI has set standards, including standards for needs-based and fair distribution of valuable resources. CEPI has managed to do this well, an excellent achievement. Virus has no borders. The COVID-19 pandemic has demonstrated this clearly. Whatever we face globally, we should work together to overcome it. And the words once spoken by the head of WHO have now become familiar to all of us. Nobody is safe until everybody is safe. Some of us can take on more. Industrial countries have a special responsibility to bear. Also to countries with limited resources, which cannot react so quickly to a pandemic of this scale. We want to strengthen the resilience of all countries. We want to consolidate infrastructure. We want everyone to have access to diagnostic tools, to protective equipment, to vaccination, to treatments. This is in all of our interest. The Federal Ministry of Education has supported CEPI from the very beginning, and I think, it's my staff working on that with a lot of effort. In total, we have provided 520 million euros, and we will continue on this road. And I'm really delighted that I can announce to you here now, my ministry as representative for the federal government will continue its support of the initiative with a further 100 million euros until 2026. Why are we doing this? We are well aware that we can only give the funds and you do a lot of the work, but still we're happy that we can support that. Why are we doing this? We want to ensure that we are better prepared for future pandemics because we need initiatives like this. They are well connected, that link research with equal access for everyone. Global challenges call for global solutions, and CEPI is such a global solution. Ladies and gentlemen, if we have learned anything from the pandemic, it is this: we must not neglect prevention. Monkeypox, polio, and Ebola, we've been hearing about these lately quite a bit, but it's not just about viral infectious diseases. We rarely hear about the silent pandemic, the increasing spread of antibiotic resistance. It's making rapid progress. Every year, around 1.2 million people die from infections with multi-resistant pathogens, and this is a substantial risk for health system, but also for the economy. There is the Global Antibiotic Research and Development Partnership. This is a charitable initiative to help research develop new antibiotics, and we will continue to support this initiative. We will also provide up to 50 million euros until 2027. This is our contribution to the fight against the silent pandemic. I want to assure you here today that Germany stands ready to partner, to be a partner. We will continue to invest in research and development so that we can react better to pandemics, so that we can prevent them. We need the entire toolbox for this, and now it is the time to fill it together. A few days ago, I heard an interesting quote. It has been attributed to the anthropologist Margaret Mead. Perhaps you have heard it already. Helping someone else through difficulty is where civilization starts. So I look forward to further working together, and I wish you a wonderful conference and a lot of progress in all your endeavors. Thank you very much. Thank you for being here in Berlin.
Minister, allow me just to say thank you so much. We talked about Germany's leadership in global health in general, the leadership you've shown in pandemic preparedness and response through your G7 presidency, and now also your support for CEPI. You are the biggest single investor in CEPI, and we really do appreciate it. So thank you so much for your kind words and setting this this meeting in that context. So thank you so much.
Thank you, Minister, and thank you, Frederick. A critical part of the 100 Days mission is eventually to develop a viral vaccine library for each family of viruses that is already known to be able to infect people. And the idea is that we would begin with those that are seen as posing the highest and most immediate risk. Dr. Swaminathan, I'd like to ask you, please, how do you see partners in the mission, the 100 Days mission, being able to coordinate their activities so that we can make progress on that vaccine library more quickly and identify those highest risk families?
Thank you so much. Thank you for that question. Very important. I think different organizations have different roles, and it would be good to hear, what the role of each organization is. And I want to, first of all, agree with Dr. Ahmed's points that he made during his intervention. Very, very important and critical points. And, we have the technology transfer program that was set up exactly to address this issue of the inequities we see in not just in access, which comes at the end, but in the research that's carried out, in the manufacturing capacity, and in the distribution of resources for each of those elements that are needed. So let me come back to what the WHO's role would be in this initiative. And WHO is the global norm and standard setting organization. And many of the work done by our other global health institutions and agencies depend on WHO's role of norm setting. And so the first, to take a step back and go back to 2015 and what happened during the West Africa Ebola outbreak in terms of the fragmented research response at that time, and that it was, everyone, I think, felt that it was a wasted opportunity in terms of not really having advanced knowledge as much as could have been done. and testing more products and so on, just because it wasn't coordinated. And this is why the member states then asked WHO to develop the R&D blueprint, which basically focuses on pathogens of epidemic and pandemic potential. And Sir Jeremy Farrar here in the first row is the chair of the scientific advisory group of that blueprint. He's been there for many years now. And what it does is basically it listed a list of priority pathogens and then developed a research roadmap for each of them, which means that you already in advance lay out what would be needed for Lassa fever, for MERS, for SARS, for Ebola, for Zika. And most of these diseases do not have countermeasures, or did not have at that time. I think we have seen some progress. And then the next step, once you have a research roadmap, is to say, okay, if you're developing a vaccine for Lassa, what would be the target product profile? What should the benchmarks? What sort of efficacy are you looking for? Is it a preventive vaccine? Is it, who will be the target audience? What sort of properties should that vaccine have? Desirable properties and ideal properties. And then you do the same for diagnostics and therapeutics as well. This then gives manufacturers, developers, and funders a sort of a benchmark to work towards. And really, I think, helps in the development of countermeasures. Very, very useful. And we saw that at the beginning of COVID, we brought together our scientific advisory groups. We had a target product profile for COVID vaccines published in March of 2020. The FDA, the EMA, everybody got behind the same benchmarks. So all vaccine developers knew what they were aiming for and what was failure and what would be considered success. And of course, that has to be modified as you go, as you learn more knowledge. What was 50% was the goal that we were shooting for at the beginning because of influenza. And we said, okay, if we have a 50% efficacious vaccine, it will be good enough. Now we would not be satisfied because we saw what we could do with COVID, but not all pathogens are going to be the same. So I think developing those lists of priority pathogens, but now we're going one step further and developing a list of priority viral families. As you know, there are a number of viral families, over 25 groups of families that can infect people. Some of them are zoonotic, some of them have human reservoirs, some could jump from animal to human at some point. And the same is true for bacteria and fungus, actually. But we're talking about viruses just now because they're most likely to cause pandemics. So we are working now with partners like also the NIH, because they've also done a lot of thinking around the prioritization of viral families. So we've set up these expert advisory groups on each of the, well, not 27 of them, but for groups of viral families. And then there'll be a prioritization advisory committee that Professor Barney Graham has agreed to chair that would actually set the methodology. And hopefully there'll be a meeting in November. We're working towards that. That'll be the first meeting of the Priority Advisory Committee that would set out the work for all of these other committees so that in the end, you will have a list of a prototype pathogen coming from each of the, and this is where it links then with the work of CEPI, because if we look back again at SARS, the work done, and we heard from AstraZeneca, the work done on SARS and MERS actually played an important role in being able to accelerate vaccine development for SARS-CoV-2. And so this is why the prototype pathogen approach would be helpful. CEPI has already announced that they will fund these platforms. Different platforms shouldn't just be the mRNA platform. We have to go much broader than that, but really focus on investing in platforms, investing in capacity. And again, going back to what Dr. Ahmed said, distributed capacity, not just in a few countries, in high-income countries, but make sure this time around that the investments and CEPI is diversifying also their investments into manufacturers around the world so that you're ready with a prototype platform as well as a perhaps prototype vaccine, so that next time around you have the genetic sequence of the virus. And again, really important, I think that we invest in genetic sequencing infrastructure and capacity, as well as platforms to share that genetic sequence data in a timely fashion so that scientists can use that immediately to start work on the vaccine. And I think that is going to be critical first step for the 100-day mission. There are many other elements. I think Dr. Ahmad touched on clinical trials, regulatory, but perhaps we can come back to that.
Yeah, well, one of the other elements, of course, is that is vital for this is surveillance. And I'd like to ask Dr. Aditifa, because the identification of a new viral threat, it may be one that we already are vaguely familiar with. It may be a completely new disease X. And that real-time epidemiological surveillance is critical to the 100 Days mission. And I wondered if I could ask you, please, what lessons do you think could be learned from the evolution of Nigeria CDC's surveillance system that could be useful for progressing this 100 Days mission?
Thank you very much. And again, thanks to the organizers for putting this together. Obviously, we're having this conversation about surveillance because your 100 days, really, the countdown should start from the moment you identify pathogen X or whatever the outbreak is. But again, the start of the countdown may be, 0 plus 60 days or 0 plus 90 days, depending on what surveillance systems are there. In many parts of the world, we still have paper-based surveillance systems. They might be aggregated by entries made into Excel sheets at district or state level or national level. And part of the challenge you have is even when these are done in a timely manner, you just don't get a real-time picture. So if you look at how records accumulate from subnational level, say like the local governments that we have, and then they have to go to the local government headquarters, and somebody has to sit down with all of these ledgers and put them together, and then they have to go to states to be aggregated, and then if you're lucky, following aggregation at state level, then they go to national level. So what's historically happened is that the outbreak is over by the time you actually get to know that something has happened. In the case of Nigeria and the Nigeria Center of Disease Control, we've been forced, so to say, as a result of multiple and often concurrent challenges to evolve the surveillance system that we have to what it is now. So, and the progress has been incremental. So first we had Ebola, and because of Ebola, we then sort of deployed collaborative open source digital surveillance platform that we have now. But with Ebola, you start off in the areas that are likely to be challenging, because you need this real-time feedback on case numbers and as they so that you can inform response. So we had introduction with Ebola, then monkeypox reemerged, and then you had a further scale up, and then Lassa fever in between, meningitis here and there, and then the pandemic struck. So in our experience, we have taken what would be a scenic route to, for want of a better description, to deploying on a national level a digital surveillance platform that can now report cases in real time. And we've benefited considerably from scaling up during COVID to be able to report case numbers daily, to be able to brief the public on what's going on daily. And I think that example, of course, then, it meant that there was trust. People had a sense that government they knew what they were doing, and could engage with the progress or none for the pandemic. But I think that if there are lessons to be taken from our experience, as I close, we can probably put this into 3 points. One is investments should be done in peacetime. Okay, so in the quiet before the storm, or after you've recovered from the last outbreak that you've responded to, hoping that you actually have time to recover, because in our case, it's usually one thing to the other. But those investments in surveillance tools, in training, in the human capacity, in the infrastructure, the equipment, in the protocols, the job aids, and all of that should be really done should be a constant investment in the background. So that's one. The second point related to the first one is usually we focus on tools, we focus on software. You know, some people just like, oh, we developed a really nice piece of software and it's been deployed, and report back to the funders. This is done, excellent job, and you get the next grant. Investment in surveillance must go alongside with the investments that are required for data management, for analysis, for advanced analysis, including the ability to sort of develop early warning systems, to forecast, or to conduct math modeling, to take data, link it to spatial pictures, and all of and complement that with all other information. So that's what I think would be the second point, because you know, if you cannot go beyond the basics, which is that you report a case number, you can tell the numbers, then you're really underutilizing the data and you're not getting the best out of all of the investments that you have done. I think the other thing linked to the first two, and speaking about surveillance in general and counting cases, is the lesson we've learned from genomic surveillance in the context of COVID, and the need to actually have that going, because one of the things that you will need as part of the efforts to achieve the vaccine in 100 days will be sort of diagnostic capability and the ability to get genetic material. And the old world order where, you know, it would be, okay, here are the samples and you ship them off to the USTDC or to the UK or something, should really not be what we continue. Is there has to be quote unquote democratization of diagnostic and genomic sequencing capacity to ensure that everybody is in tune with this objective, and in looking after your national security, you then are able to contribute truly and properly to assuring global health security. So I'll just stop there for now.
Great, thank you very much. So, Mr. Delso, we see without a doubt that global collaboration has been crucial in the response to COVID-19, and where it was lacking, we got into deep trouble. How can organizations like your own HERA and like SCADA in Japan and of course CEPI, how can we all work together to maximize the impact of these investments in vaccine development, and crucially to make sure that we're not all going for the same thing, and that we are really spreading the workload and collaborating rather than all working on the same thing?
Thank you very much, Kate, for your question, and thank you very much for the invitation, because I still feel like the new kid in town, you know. For those who don't know HERA, we are called the European BARDA. But one day, I'm sure BARDA will be called the American HERA, but not now. It will come. Maybe I would like to start with a word of caution, of course, because to some extent, we are talking between converted. What do I mean by this? We are all convinced that health is important and we need to continue to invest in health. But we need also to be realistic. Outside of our world of health, you have people who are also facing other crises. And you know, human beings have a great tendency to forget about crisis. You know, they were in COVID crisis, COVID is still there, but people have a tendency to forget about the crisis and focusing now on other problems, you know, energy crisis, for European energy crisis, Ukraine and so on. So we should be realistic that whatever we want to do in the health sector, we will need also to convince those who are not converted. We will need to convince people outside of this room. And I believe this is a very important message, because talking to each other is nice, but we need to convince politicians, we need to convince public authority outside of this room. Third element, and I believe we all agree, we need to invest in preparation. If you react only when there is a crisis, it's too late. And that's certainly one of the lessons of the COVID crisis. It's in anticipation that we can be ready. You know, I've heard several times, vaccines were available in a very short term. Yes, except of course that they were the result of long-term investment in research. They did not pop up, you know, suddenly in 1 month. Actually, they were already a long-term investment in those technologies, which are, at the end of the day, were able to develop the vaccines. So its preparation is key And that's something we all need to invest in preparation if we want to be ready for the next crisis. Otherwise, I can tell you one thing, we will be too late. And coming back to my second point, that message that we need to invest now in preparation for the next crisis might be a difficult one, simply because people have forgotten about the COVID crisis and have other priorities. That's something on which all of us, we need to convey this message to everybody. Third element, coming to your questions. Yes, a health crisis is global now. We don't live in a world where, health crisis would be limited to one part of the world and you can stop there and you can limit it there. We know that we live in a world which is in a global world. I still remember when the first cases of Omicron came in South Africa, were detected in South Africa. European, we took some measures, we stopped flights, we stopped everything. Still, 2 weeks later, Omicron was in Europe, and a few weeks later, everywhere in Europe. So we cannot stop like this crisis. So we live in a global world. So the next message I would like to convey to you is that we need cooperation between us. We need cooperation between all parts of the world. More developed country, maybe a little bit less developed country, but we cannot leave anyone behind us, because all parts of the world have the same importance, and we need to make sure that everybody gets access to the same technology, to the same vaccines. Now, turning to the initiative of 100 days, that's a very important initiative. And as you say, Frederick, it's a goal, it's a target. We are not yet there, but we need to do everything to be able to do it. How can we do it? First of all, we need to reinforce cooperation between the different actors. As HERA, we have already signed an agreement with BARDA for cooperation. We are in close contact with CEPI. We are in close contact with African CDC, and I really regret that Dr. Ahmed is not with us today, but we know the reasons, not very good reasons. We talk to African CDC. We will talk. I'm going to Japan. We'll talk to Japan. So we need to have a global approach. We need to talk to each other. Otherwise, we will have duplications. We will not be very productive. So first element, talk to each other. Second element, on surveillance. It's important. Surveillance is key, as you explained. Surveillance is key. But we need to make sure that those platforms which are being developed everywhere talk to each other. It would be stupid that you develop a platform in Nigeria, another one maybe in Japan, a third one in the US, and the last one in Europe. We are working on a platform, and WHO is working. But what we want is really to develop a platform for surveillance, which is linking all the different platforms. So it's not a question of taking over. That's not the purpose. We don't want to take over. We simply want to make sure that everybody works together on that. And finally, maybe on the question of vaccines, which is a very fundamental issue. And when you talk about vaccine, it's a very difficult issue for two reasons. First of all, we need the technology to develop those vaccines very fast. And we have seen how important it was, of course, to have the availability of vaccine as soon as possible. But the second element, we cannot ignore that also we need to convince people to be vaccinated. So what we call the last mile is also extremely important, to make sure that actually we can deliver those vaccines to the arms of the people, because otherwise developing vaccines which are not being used will not lead us anywhere. So we believe this is also something which is extremely important. What I can tell you on behalf of HERA, so this new kid in town, we really are willing to partner with everybody in the world. No discrimination. We want to talk to, to the US, to Japan, to Africa, to Latin America. We want to talk to everybody. We want to talk to CEPI because we believe your initiative is extremely important. And I can already tell you also that we are in the process of organizing also an event in Brussels on what we call the second generation of vaccines for COVID. Because that's also something which is striking, which, I'm relatively new to this field. We have new variants, and then we try to develop vaccines to be adapted to the new variants. But by the time we have those new vaccines, a few months have already elapsed and people have been affected by the new variant. So what we need is to try to be more anticipatory, to try to develop technologies which try to protect us against different types of variants. So we are going to organize such a conference in November. And of course, all of you will be invited, because that's coming back to what I say, it's only by partnerships that we can achieve something. So again, thank you very much for having invited me. But again, let's not be complacent. We need also to spread this message outside of this room. Mm-hmm. Thank you very much.
Thank you. And I'd like to come to Dr. Rodriguez now. When it comes to the world's capacity to be able to track the emergence of a new disease X and to swiftly identify it, which of course is where our countdown starts. where do you see the greatest weaknesses, and what, in your view, can we do to bridge those gaps, to plug the holes?
Yeah, thanks very much for the question, Kate. And before I respond, I just want to acknowledge the representatives from the German Ministry for Research and Education in the room for the announcement today. It's incredible to see the additional support for CEPI. It's critical, but also the German leadership in maintaining the focus on the 100 Days mission. We're all really grateful. It's not just for CEPI, but it's going to help all of us in the middle of COVID to actually prepare for the next pandemic. So we appreciate the announcement today and the ongoing support, and especially in Berlin, I think it's important to highlight that. So thank you. Okay. To respond to your question, Kate, I'm also here, I think, a little bit to shake up the room by reminding us that as critically important as vaccines are, and as much as we need to invest in developing vaccines and the 100 Days mission, there are other countermeasures to counter pandemics. And so I'm gonna remind you of that through two stories, and focusing on the testing need and the fact that we need a 100 Days mission for those countermeasures. So let me take everyone back, as sad and painful as it is, to May, June, July of 2020, when the first patients were just being enrolled in the clinical trials for these new vaccines. We weren't even aware of how critical and how powerful they would be, and we were already in the middle of a testing crisis. There had been some molecular tests made available, PCR-based tests that had been available in some laboratories that people were beginning to access, but we did not have an antigen test 200 days into the COVID crisis. The test that we're all now used to using in many parts of the world to protect ourselves and our communities and have become a mainstay of the response still didn't exist. They were still 2 months away. And we forget that we had a testing crisis because we had not done the preparedness and preparation for diagnostics for this new coronavirus. And so the recognition that the 100 Days mission for countermeasures needed to be not only about vaccines, but also about diagnostics, that in fact, diagnostics were going to be the first critical need in a new global outbreak, was clear to the UK in the development of the first report on the 100 Days mission, which was presented at the G7 last year. FIND was asked, and to working closely with CEPI, could you put together the parallel plan for the 100 Days mission for diagnostics? What does it look like? What does it entail? How do we need to support it? And it's actually much simpler, fortunately, because the risks in diagnostic development are much lower than the risks in vaccine development. Even with these amazing new vaccine platforms, they're still risky. We know what we need to do to develop new molecular tests for a novel coronavirus, for Lassa fever, for most any viral pathogen, and for pan-coronaviruses, or even for disease X, how to be ready to do that. We can cost that out. What is the R&D agenda for that? We know how to develop new antigen tests and rapid tests and self-tests. So we put together that plan. We costed it out and laid it out for 10 priority pathogens aligned with CEPI and worked with the CEPI team. And that was in that initial report that came out last year. And it's costed out over the first 5 years of about $50 to $80 million to develop that those priority pathogen tools. And importantly, because of the major inequities in access we've seen not only in July and August of 2020, but throughout the COVID pandemic, a plan on what it would mean to have local manufacturing those products so we could scale up production equitably everywhere in the world it was needed, and not just in parts of the world where only the high-income countries could access it. So that's the good news. The 100 Days mission has a clear plan on diagnostics. It's costed out. The bad news is it's unfunded. So when CEPI 2.0 did its replenishment recently, very successfully, they worked closely with us to say we're going to try to get this in there, but the advice and the response was this is about the vaccine 100 Days mission, and CEPI 2.0 is vaccine component, not about diagnostics. We've had fruitful discussions through multiple partners and through Act A about funding the 100 Days mission for the diagnostics component, but it is as yet unfunded, and that's a problem that we need to redress. Second story is, how do we know that maybe we forgot about how bad things were in 2020? Maybe we don't want to remember the testing crisis, and maybe we can move much more quickly next time without a big investment in the 100 Days mission for diagnostics. Well, we know what's happening right now in Uganda, and we saw what happened in monkeypox. So in a few hours, I'll be on a call. The CEPI's Joint Coordination Group is having a call to update us on the progress we're making on vaccines for the Sudan strain, and I'm going to be discussing the progress we're seeing on the diagnostics for the Sudan strain of Ebola. And the news is pretty bad. We're, I think, close to 100 days in to this outbreak and was first identified, And even though we had good Ebola tests for the Zaire strain that were used and developed during the West Africa outbreak and have been used in recent outbreaks for the Zaire strain, we actually don't have any valid molecular diagnostics. The 3 that were authorized through the emergency use process for Zaire strain don't actually detect reliably Sudan strain, and the rapid tests don't exist, and no one is actively developing them. So right now, we are all dependent on a very hardworking team at a single virology institute in Uganda, the UVRI, to manage the response to this outbreak with all the testing. And they're holding up well right now, but if this spreads to a broader part of Uganda or spreads beyond Uganda, we are not prepared to respond with accurate diagnostics, let alone where that production might take place. So we know today the 100 days mission, because Ebola is in that plan, has not yet started for diagnostics. And monkeypox tells a similar story. So, and I'll just briefly mention that and then stop. But when the monkeypox, as my colleague knows well, is endemic in Nigeria and has been diagnosed in hundreds to thousands of patients in Nigeria and in the region for several years, and has significant morbidity and mortality. There's been a big effort from Nigeria CDC to get more attention to this on the testing side, and it has fallen on deaf ears. And there's been no effort to develop a commercial monkeypox test that can be widely used as a rapid test or to bring commercial molecular tests. So relying on their test that they've developed internally to address monkeypox. And as soon as it became a global challenge in high-income countries, we went from 0 companies developing a monkeypox test to 53 within a month, uncoordinated. No clear plan about whether those tests were accurate. They had not been validated, but they had emergency use authorization from somewhere. And then as the monkeypox outbreak has waned in high-income countries, those companies are shutting down that effort. And we will still not have a test in Nigeria that we can use. So the point being, the 100 days mission around critical pathogens that we know are actively risks and threats or causing active outbreaks has not yet really started. And that's, I don't want to take away from the intensive support we've seen for CEPI on the vaccine agenda, because it's absolutely essential. But as we've all known from COVID, it's not vaccines or something else. We need vaccines and tests, and we need to heighten our attention to the diagnostics component of the 100 days mission if we want to be prepared fully for the next outbreak.
Thank you. Frederick, I'll come to you now, and then I would like to open up the floor to the audience. We've clearly, the 100 days mission is a bold ambition, and we are not there yet. But assuming that it can be technically achieved in the future, how are we working to ensure that the world can enable access to those vaccines that are developed in that 100 days?
Well, that's a big question, but really the important question, because at the core of CEPI at least is, and for all of us, is really this dual mission of acceleration and access. And so I think there's a number of things all the way from when we start on research and development and actually looking at the characteristics of the vaccines we need and diagnostics we need and therapeutics that we need, that those are adapted to the needs globally. So it starts really early on in the development process, and then carries through all the way through to practical things like contracts and how these tests and vaccines that we develop can be deployed in the field. But from a CEPI point of view, we're also increasingly recognizing the importance of working on the systems associated with this. So it's more than the individual pieces, it's actually how the whole system is set up. And so that is, of course, related to the big discussions going on now at the World Health, or led by the World Health Organization, and taking place in terms of these negotiations of some form of not treaty, but instrument, but also the whole system of who does what and the architecture questions that we are all looking at. So I think we need to move from not only a principles-based but also a systems-based approach to these questions.
Thank you. So I would like to open up for questions from the floor, if I can, please. There's somebody walking around with a roving mic. So can we take that question first there, please? Thank you.
Yeah, thank you. My name is Alain Salani. I work for MSF Access Campaign. I have basically two questions. The first one is on the concept of a library of vaccines. So even if we assume that we reach the level of coordination between the different entities that are working on pandemic preparedness vaccines against prototype viruses, I think it's something that Dr. Sumia mentioned yesterday about R&D inequity, and I think that was very starking during the COVID pandemic. How do we avoid this situation for the pandemic preparedness work, knowing that most of the entities that are working today or have plans to work on these vaccines are actually high-income countries? And even when you look at the CEPI, I mean, maybe to the exception of Indonesia, all other countries that gave you funds are actually high-income countries. So my question is, how do we avoid the same situation? How do we make sure that if and when we will have this library, that access to the technology that is being developed is not going to be the privilege of only the high-income countries that funded this research? And my second question is, Dr. Christensen, you've touched upon it a bit, but maybe you can give us a bit more of detail. In the specific case of CEPI, when you're giving funds to a given company to work on an investigational product, what is done to make sure that at the end, a manufacturing partner somewhere in different regions in low and middle income countries will actually get access to this technology? And let's take the example of Moderna that received some funds from you. Let's think about the WHO hub in South Africa. We as civil society have been asking for Moderna to share the technology. Didn't happen. Moderna also received a lot of money from the US government, as you know that. So it didn't change their attitude. How do we make sure that in future efforts, the situation will change? Thank you.
Go ahead.
No, thank you for those questions. Really, very, very important issues. And so on the libraries and making sure that the vaccines actually are accessible, I think it ties in with your second question in a way, because of course from what we can do as CEPI, we are always very clear on saying that we are enabling equitable access, and that we are can do everything within our powers to help to do this. But it does take the global society as a whole to be able to really push for this, including, as you say, from when large governments make their investments, that they also push for having equal access provisions in their contracts when they make those investments. So in the examples for us, we have different mechanisms to help do that. So getting into sort of the technical details of making sure that the contract partners actually sign up to being able to provide the vaccines to the people in need and at prices that are acceptable. And if not, that we have provisions to be able to transfer the technology from that partner to a partner who is willing to live up to that commitment. So that's kind of one example of an element that we put into the contracts, and then we have so far focused on having pre-selected and willing partners to be able to do that tech transfer, because doing tech transfer is such a complicated affair that we need to make sure that it's actually set up so that it can happen in practice. But there are a number of other things that we also put into our contracts, and I realize that ideally many people would like to see that in further detail, but we do actually based on the negotiations and the negotiations power that we actually have in the concrete situation, we can put various pieces of this into practice. So for the Moderna example, we were very, very early on. We put in $1 million. As you know, and I alluded to, they later received billions, and so of course the leverage that you have in a contract negotiation like that is very limited in practice. It also has to do with when the investments are made, because if you make them when we make very, very early investments, it's in a phase of great uncertainty as to whether these vaccines will actually develop and become vaccines that can be used. And at that stage of the process, it's harder to be very, very concrete about the end result. So both the size of the investment and the timing of the investment is going to be critical for being able to really push for that goal that we all share.
Thank you, Frederick. I'd like to just ask Dr. Ogwell if he'd like to come in on that response.
Sure. No, thank you. Thank you very much. Indeed, thank you to the colleague from MSF. I didn't catch his name, but two things that I would like to add here that concretely needs to be done. If public money goes into the development of any health product, that needs to be a public health good and should not be sold at huge profits to the detriment of the public. So this is one of the contracts, but it must be done. The second thing that must be done is, especially in the situation of emergencies, pandemic like we have here, the TRIPS flexibilities need to kick in. They're self-executing. They don't need a lot more discussion and further negotiation. The Doha rounds were enough. So the TRIPS flexibilities need to kick in. In this way, we'll be showing that we are serious about public health. Otherwise, if we start renegotiating the TRIPS flexibilities again, then there was no need of being in Doha all those 6-7 rounds. So those two things need to be done concretely. Then we'll know that we are doing things differently, and it will not be the privilege of those who have the resources, as is the situation now. Thank you.
Thank you. Can I take another question? Gentleman there, please. Oh, sorry, I'll take, sorry.
Yes, I'm Koopmans Erasmus Medical Center. I'm about One Health, and we've seen the launch of the quadripartite One Health Joint Action Plan yesterday, and that's where many diseases come from. So my question for CEPI, maybe also find, is where are we with thinking about animal or human-animal interface vaccines, where also animal owners may want very different combinations than we are thinking of, like Brucella plus MERS, for instance.
So indeed, very, very important. One Health is increasingly important, I would say, in terms of pandemic preparedness and planning. And within the context of the portfolio that we are looking at and supporting right now, we have made a conscious decision that the starting point for us is for Rift Valley fever within the portfolio that we have at present. So that is where we are launching a very concrete One Health initiative. And we'll be looking at vaccine development for both, the animals, the domestic animals in Eastern Africa in particular, and also then for humans in connection with each other. And we're just at the starting phase of that. And within the available resources, that's where we are starting. But I think, as you point out, this is definitely an area to strengthen further. So I don't know, Bill, if you want to
just totally appreciate the question and agree. And just one comment, we definitely take a One Health lens, in addition to looking at how do we monitor zoonotic infections in animal populations that may well be the next emerging human health crisis. And I agree, Rift Valley fever is one of the ones we're focused on. We also think that there's an existing issue, which is antimicrobial resistance and the link between animal health and human health. So we're focused on developing the tools that can allow us to look at the joint approach to AMR in a One Health approach, and we think that effort will strengthen the effort to look at the emerging zoonoses as well. So it's, but it absolutely needs to be a unified agenda. That's the likeliest source of the next pandemic.
Okay, could I take this gentleman at the third row from the back? Thank you.
Hello, this is Henry Lee from the Global Health Security Consortium and the Tony Blair Institute. I have a quick remark and a question. So Professor Ifidayo is absolutely right about peacetime investment. 100-day mission needs to be complemented by actually a 365-day mission to strengthen routine vaccination and also build sustainable capacity in manufacturing and delivery. And to contribute to this goal, the Global Health Security Consortium has just launched an initiative called One Shot, which aims to boost adult vaccination in peacetime. And we really value the support from global health actors, including CEPI. And to Dr. Ahmed and Pierre's important point, we really need a holistic approach from invention to injection. And to make this approach happen, we need to ensure that the 100-day mission and the 365-day mission, such as One Shot, are properly linked up so that routine adult vaccination can learn from and benefit from 100-day mission. So the question is, what does the panel think about are the key transferable lessons from 100-day mission that can be incorporated into the R&D, manufacturing, and delivery of routine preventative medicines in general? And to what extent is the mission approach itself, for example, applicable to routine vaccines development and deployment? Thank you.
Thank you. Is there anybody in particular you would like to answer that?
Maybe,
Sorry.
maybe we could start with Dr. Ahmed.
Thank you. Very good question there. And let me focus on just one key lesson that we need to learn and then transfer as we do the 100 days and the routine, if you want, vaccination. Systems. We need to ensure that our systems, from the moment of receiving the vaccines at country level to the moment of going into people's arms, those systems have been strengthened. They'll be useful for any vaccine amenable disease condition, and they are going to be able to be present throughout, and government usually will be able to take over this in a while. So systems for vaccine distribution and eventually actual vaccination, those need to be strengthened. And the failure in systems globally, so vaccines and vaccination not being able to be done as efficiently as we thought they would be able to be done during this pandemic. Let's strengthen those systems and make them available for any vaccine that will be required by the public, especially at large scale. Thank you. Thank you.
Thank you. Dr. Swaminathan, could I ask you to address that question as well, of how the missions of the 100 days mission, but also this sustainable capacity, building this sustainable capacity in more diverse regions are going to happen together?
So maybe I could add to what has been said already. I think this sustained capacity has to be from end to end. It has to start with the researchers and the academic centers and the universities getting support. And really, I think national governments need to step up their support for research. It can't all be through donor funding. And I hope that governments of at least of low and middle income countries will recognize the value of investing long-term in science and in research. So basic science, then clinical trial capacity, clinical research, epidemiology. I think with Lassa fever, for example, we are seeing the need for good epidemiological studies to pave the way or prepare the ground to test a diagnostic or a vaccine when that is available. You need the laboratory capacity, you need biorepositories. All of that work needs to happen for the pathogens which are endemic or which are of public health importance in those countries. And so a West African consortium, I think that's led by the Nigeria CDC, for example, working on Lassa and so on. So regional, I think, networks. I know the Southeast Asia regional countries had come together to form a consortium. Just before the pandemic, they had identified, I think, Nipah and chikungunya as some of the priority pathogens. And this is really the kind of approach that we need in the inter-epidemic period, so that with core protocols developed that have been reviewed by ethics review committees, as well as a regulatory, and I think we did not mention the importance of the regulatory agencies in the 100-day mission, because for the reason for some of the speed with which vaccines became available is because of the collaborative procedures that were put in place by regulatory agencies, the reliance on each other, so that you don't have a country by country approach to approving products, but really relying on, again, either regional regulatory agency or like the European Medicine Agency, the African Medicines Agency that's now being developed. I think those are very, very important to also work on during peacetime. So I think there are a number of different elements around how products get developed and then used in systems, and also the policy and regulatory pathways, and then procurement. Who's going to do the procurement and the distribution? Pricing was mentioned as an important essential element, and we can learn lessons from COVAX and prepare for the next outbreak. But again, it has to be also for diagnostics and drugs. And we saw that there were big challenges during this pandemic.
Could I weigh in on the diagnostic side for 1 second? And first off, I think you've done the communications at the department at CEPI a huge favor, because I think the 365-day mission is the next program. I think it's absolutely critical. For vaccinations, you've clearly made the link, and your group has made the link between primary healthcare and pandemic preparedness, but not everyone makes the link as easily. And I'll say on the testing side, it's exactly the same. We think these two things sit alongside each other and are deeply integrated. And the way we talk about it is if people don't have faith to come into a clinic on Monday sick and know that they're going to get tested for what's wrong with them, and you're going to find bacterial pneumonia or influenza or RSV, they're never going to come in on Thursday with loss of fever. You're not going to find it. So we need to test for things that are routine on a Monday to test for things that are rare on a Thursday. If that system doesn't work, our surveillance systems won't work. And so it's a critical issue that actually pandemic preparedness and the 100-day mission are linked just innately to the 365-day mission.
Mm-hmm.
So thank you for that comment.
Okay, thank you. I take this gentleman here, please, in the middle. Oh, sorry, sure.
Okay. Well, thank you again for the opportunity, and again, great thanks to you for articulating the 365-day mission, which is basically everything that needs to be done in peacetime. But I thought I'd make a couple of points, maybe 2 or 3. Yes, we're talking about vaccines. The issue about diagnostics has been mentioned and actually refined just before now. And I think that perhaps in the whole preparedness and response and simulations, I think it would be nice going forward when we have these simulation exercises to actually extend those to, what happens when you develop a new vaccine? How are you going to develop that? What happens when you need a new diagnostic? How are you going to put that in? Because then that covers the full scenario in the context of outbreak of pathogen X or not. But so that's that. So the second point is, speaking about diagnosis, is in the 365-day mission, I think it's important that, of course, we establish routine diagnosis, but and I think it was said earlier in the session in antimicrobial resistance, is this idea that people look at surveillance separate from diagnosis and clinical management is an argument that I've made before, even with WHO colleagues in the region, when people were coming up with business plans for VPD surveillance. And I was like, look, VPD surveillance has to be about people present with pneumonia, meningitis, or whatever in the health center and can get diagnosed. Because when that happens and you improve case management, simultaneously you get surveillance data. Okay, the problem we have in many settings is surveillance is sort of considered, either donor-sponsored or research, and we need to change that mindset. And of course, now take into account all of the previous recommendations in global health that were well intended also affect the ability to deploy diagnostics. I'll give you an example, and I'm just thinking of, for many years across the continent, if you had a fever, you got a course of chloroquine. Okay. And whether we like it or not, I'm sure it wasn't intended, that basically set the tone for generations of nurses, community health care workers, doctors, that malaria is the only cause of fever. Okay, so you gave chloroquine, and if a person is still ill, you assumed later on that they had chloroquine resistance. We actually never invested in the space of fully investigating fever to find out what exactly is going on. And we're in a situation now where everybody's conducting acute febrile illness studies in 2022 with a view of trying to tease out the full repertoire of pathogens that might be implicated in acute febrile illnesses. So I think, and then the final point, diagnostics, whether laboratory consumables for genomics and all of that. Whether you want to talk about democratization or manufacture, I think we've got a challenge where the narrative is one where people talk about, oh, there's limited capacity to do this in some parts of the world. But then you find out that actually I pay more for every genome I assemble than somebody sitting in Germany. And then you've got to ask yourself, how, what are my GDP per capita, or how can I be paying more for a genome sequenced in Nigeria compared to one sequenced in Berlin, for example. And the same applies to a lot of the diagnostic tools that are available, that that plan for equitable distribution to make sure that manufacturers either have partners or actually have agents in the continent. If you take Illumina, for example, and I'm sorry to mention names, I think Illumina has no agents in the whole entire continent, or maybe they've got an office in Cairo now or something. But I think, again, these need to be taken into account. We've made progress in that conversation with respect to vaccines and having these hubs around for technology transfer and all of that. And that needs to be done also for diagnostics, because as I said, your day zero would be 0 plus anything up to infinity, depending on what you have available. Yeah.
Thank you. I can take another question. Sorry, the gentleman here that I was going to. Thank you.
Thank you. Niklas Kramer, my name, from the German Federal Ministry of Health, Health Security. Sorry for having the last question, I guess. Bad to hear from Uganda that we are not really prepared. So I guess it's really relying on the teams on the ground to control the outbreak. In the German G7 presidency, came up with this pact for pandemic readiness, where we try to focus within the overall WHO strategy on surveillance and workforce. With regard to surveillance, thank you so much what you shared with us, Mr. Adifa. Quick question, what would be your single wish also to G7, WHO in this regard, maybe apart from investments, also some other concrete actions, items you can think about? Sorry about that last question. Thank you.
And anyone who would like to?
I've been offered a blank check and now I'm struggling. Okay, so, well, my wish for surveillance is one, a change of philosophy, one that looks at surveillance in countries where, yes, perhaps they're not doing as well as the European Union or countries in North America. That philosophy that comes to that brings surveillance to our part of the world as a global health security issue is basically, you're not interested in me primarily. You're interested in protecting yourselves or restricting, assuring your health security by making sure I can find out what's going on in my setting and reporting. And believe it or not, now we can tell that difference in conversations. And just a few days ago, hosted a team from WHO and had to sort of say, well, we're friends. I'm fully supportive of everything WHO does, but I'm going to start off today by scolding you because all I have had today are requests about what you want from me. You've not actually asked me how I'm doing with my multiple war fronts that I'm having to deal with, but you're requesting for data, you're requesting for sequences and all of that. So I think that that needs to change. So that's one thing. The second bit, obviously, is personally in my setting, as I tell colleagues, is I want scale. Okay, so for my surveillance system in every part of the country, in every local government, my next area of growth is I need that to be in every health facility and in every lab. And I need surveillance clinical data to speak seamlessly or link seamlessly with lab data, with geography, and I need the capacity to pull all of those big data points together and paint a full picture at any point in time, not half a picture or a quarter of a picture. I need a full picture with high resolution, all the pixels that are possible. So, I mean, this is my sort of dream for my surveillance capacity in my country, and of course, the human capital that is required to make the most use of that data. If I have any other ideas, I'll come back and catch some more of those.
Thank you. We're coming very close to the end. I wanted to take one more short contribution from Dr. Ogwell, who has his hand raised.
Yes, sorry, technology. I wanted to make a very short contribution regarding preparedness. I don't want to call it pandemic preparedness because we hope another one will not be coming soon. But all these outbreaks, all these emergencies, they start and they end at the community. And the reference to the current Ebola virus outbreak in Uganda is very apt. We must empower the communities so that we are able to know very quickly when there is something new, something that is not normal. We must empower the communities so that they can be part of our surveillance system. They should be part of our response system. If we don't empower the communities, then we don't get very good results. And that is why for us, as Africa CDC, the Africa Union, community health workers are a core of the health security infrastructure here on the continent, and I believe strongly globally as well, so that we know what's going on at the community level and we are able to feed back and with what the right thing to do is for that particular community. Our outbreaks, our emergencies, our pandemics, when another one comes, will start and end at the community, and that is where our focus should be when it comes to early warning systems and when it comes to rapid response. Thank you.
Thank you. Thank you. So, Dr. Christensen, can I ask you just to sum up a little bit?
In 30 seconds.
I'm going to give that job to you.
Thank you. No, thank you so much. And I think to me, three reflections. One is I think there's this discussion shows the benefit of actually having ambitious goals, ambitious goals for acceleration, ambitious goals for access, and to really guide us and focus our attention. Secondly, I think that the discussion has shown that this is so multidimensional, and it takes a village, as I think it's being said, and it takes a village both in terms of across different technologies like vaccines and diagnostics and therapeutics and surveillance and all the other pieces, but it also takes partnerships across the global level, the regional level, as we've discussed, the national level, and not least this last important point at the community level. So partnerships is critical, and I think that's one of the core things that is really coming out of this discussion. So thank you so much to the panelists, and thank you for your attention.
Yeah, so thank you all for coming, and thank you to all our panelists for this contributions to the discussion. Thank you to Germany for the contribution to CEPI, and thank you all for your contributions to the 100-day mission.